international meeting. So,
yes. Hello, everybody. It's my second time to Riga. We have a lot of cooperation with Professor Leia and the young group in the team, and they are, I would say, a highly estimated group. They represent Latvia on the top level in this field. And the reason we came here also with a former fellow of mine, Dr. Boncham, who gives a talk in a minute, is that we were invited to see this wonderful project you may have heard. It's called KISTA, led by Professor Leia, which intends to prevent gastric cancer by eradication of Helicobacter, which is pathogen, and you know it, and you will certainly learn more during this session. And being updated, so it's a pleasure to be here. We enjoyed life in Latvia yesterday evening. Not in the nightclubs, but just in a nice restaurant with a lot of interaction. Thank you for having us here. We enjoy and we listen now to your presentation. Thanks.
Actually, that was my mistake because I took the wrong sheet. This is definitely the Helicobacter and microbiota study group in last meeting. But this is my great pleasure to introduce Jan Borgschenk, who is going to speak on gastrointestinal microbiota. And I was just noted that it is necessary to speak in the microphone because the session is getting recorded. So to have the speeches, the questions recorded, we indeed need to speak to the mic.
If you tell me where it is.
It's just on the
Somewhere on?
No, it's just on the
Ah,
so you just speak
this
to
one?
it. Yeah.
Oh, okay. So if I stand here, it should be fine, shouldn't it? So I try not to move away from here that the microphone will get me, and I hope you all can hear me. It's not such a big room. So yeah, thank you, Marcis. Thank you, Professor Malfettainer. It's an honor for me to be here and give a little overview on this topic, gastrointestinal microbiota, opening a black box. It's still a bit of a black box to me, and I was quite relieved when I heard yesterday morning one of the leading experts on that field saying the sentence, dysbiosis is the knowledge of ignorance. So it is a bit that we now just opening this black box, and we understand that it's very relevant and that there is, however, still very much to learn. So we are just at the beginning to grasp what relevance there is. Just go further with this. I have no conflict of interest with that. I have a few topics that I will cover, so we just give you a bit of a broad overview where we are at the moment. And what I would like to start with is a brief introduction. Where does the microbiome come from? So the microbiome obviously covers different organs, so we're not talking about the gastrointestinal system, but also about skin, hair, the ears, the airways. So they all have their microbiota composition, and they're influenced by several factors that only start very early in life, in your mother's belly, if you would say so. It depends on the microbiome composition of the mother, if there are any infections, if there are any, even the health status of the dental health status is relevant, and then obviously the first step for the individual then to prone the own individual microbiota is the method of birth, or the way of birth. Is it a vaginal delivery or is it a cesarean section? So there already is a very decisive factor that has a major impact, of course, and in the first year we know there is a difference if baby is breastfed or just gets formula. There is an impact on the microbiota composition. The environment plays a role, obviously host genetics and how your immune system is primed, but also if you get antibiotics quite early in life, and then further on, especially in the early years, what diet you have and what environmental influences there are. We know that if you look at the gastrointestinal tract, especially the intestines, that different pH and different composition, the exposure to different antimicrobial substances also modifies not only the abundance and but also the composition of the microbiota in the gut. So why is that relevant? Where are the fields that we know about that something could change, could alter, and have an impact on everybody's health? Well, we know now that the gastric microbiome is much more microbiota is much more diverse than we expected it to be. So the stomach was for decades to be thought to be a sterile organ. Then there was the exciting discovery of Helicobacter pylori, and everyone was really surprised to see that the bacteria could survive in this hostile environment. But now we see that there are actually many more species and taxa that are present in the stomach, which are now available to look at with modern techniques. But we also know if H. pylori is there, it basically dominates. This is mouse data, but you see also from the human samples, if H. pylori is there, it dominates everything else, so it kind of pushes away what else happens in the stomach. This is a study from Christian Schulz, now in Munich, formerly in Magdeburg, who has also shown that the composition of the upper GI microbiota, going from oral samples, stomach, duodenum, also comparing aspirates, A is for aspirates, and biopsies, that there is quite of a consistency if you go from the oral cavity down, if you take the Helicobacter out with the distribution of the taxa that are present. It only changes, as you see here, H in the end is for H. pylori positive. When you have H. pylori, then this diversity really drops in the stomach, because then, as just said, H. pylori is dominating what's happening here. So he also showed with different techniques, as I said, there are aspirates, A is for aspirates compared to biopsies, Helicobacter positive, Helicobacter negative strains, as for stomach, that there is a different distribution, but you can also see it's very relevant when you look at these studies and you also want to set up one of these studies, what technique you use. So you can see here Helicobacter positive spectrum with derived from a biopsy shows what we expect, but if you just take gastric juice aspirate, you get a whole different composition. So it also is very important at which niche you're looking at when you want to interpret these data. It has also been shown that there are different distributions when it comes, for example, to esophageal microbiome, and you have reflux disease with or without Helicobacter pylori. So again, in a Helicobacter pylori positive stomach, the Helicobacter might dominate the stomach, but the esophageal microbiota is much more diverse, whereas in a Helicobacter negative stomach, then you have a more flat panel when it comes to there, and then you have more option that these actually with lipopolysaccharide production can trigger further inflammation, especially in reflux disease. This is a very exciting study from the group from Porto that has just been published this month in Gut, showing that you have dysbiosis and a reduced diversity in patients with gastric cancer compared to patients with gastritis. So you can, even when you plot the principal component plot, you can see that you can very nicely, just by looking at the gastric microbiome, you can separate gastritis from cancer patients. And it's also been shown, interestingly, that in gastric cancer patients, then the non-Helicobacter proteobacteria are actually dominating here. So when the cancer develops, that is a Helicobacter-driven disease, you have a shift in the microbiota that then is completely different. So here comes the first hint towards one of the main problems when you study microbiome or microbiota in different organs, is the hen and egg problem. So is the different composition responsible for the disease, or is it modifying the disease, or is actually the disease or presence of the disease responsible for a different distribution? So the Porto group could also show that specific taxae are differently distributed. They looked in different populations from Portugal and from Chile. You see that the Chile difference is not as dominant as it is in the samples from Porto, but overall they could derive a whole bunch of bacteria that are more pronounced in gastritis, whereas there's another group that's more pronounced in gastric cancer, and from that they calculated a so-called dysbiosis score with which they could really differentiate again gastritis then in Porto, in Chile, and in Mexican populations from gastric cancer populations, just based on the microbiome. So this is the stomach, but obviously I just mentioned before that we're going further down, and the number and diversity of bacteria increases when we look further down in the gastrointestinal tract. And irritable bowel syndrome is one disease where the microbiota is in talk for quite a while. So you know that in the intestine, the bacteria are very, very important, not only to maintain homeostasis in the different mucus layers, but also to continue regulate inflammation, ideally with a healthy microbiota, maintain pH, nourish epithelial cells. So there's also metabolic effects that the microbiota provide. Also, for example, bile acid metabolism. I'll come back to that in a second. And completing the digestive process. But if there is inflammation, if there is increased permeability, for example, by decreased epithelial barrier function and bacterial translocation or local inflammatory processes, then this can all get out of balance. And then again, we're coming back to the hen and egg problem. Is the microbiota responsible for these problems, or is it because there is inflammation that we have a shift in the microbiota? This is a summary published 2 years ago by Gerhard Holtmann in Lancet Gastro, also showing that you have clearly a shift in the composition of your gut in patients with IBS compared to those without IBS, and that goes along with increased epithelial permeability, inflammation, and a different pattern of cytokine release. So this all plays a major role, and it's get more and more acknowledged that the microbiome is a central player in this so-called gut-brain axis, also modifying the response between neuronal processes and the intestinal organ that really modifies your health and well-being. And factors like antibiotic treatment, gastrointestinal infections, and diet as a major factor have an impact on this, mainly by modifying the gastrointestinal microbiome. It's not only IBS, it's also IBD. So we know that the different bacteria composition is can really separate it between patients. This is a bit difficult to read, but it means Crohn's disease, healthy individuals, and ulcerative colitis. It's quite interesting that you see patients cluster more closely to healthy individuals, and that Crohn's is so separate. We would have expected a bit of a different plot. But again, the story here is actually quite similar to what happens in IBS with regards to the influence that the microbiota have. So with the different composition, bacterial translocation and activation of certain patterns, you get intestinal dysbiosis. And dysbiosis and inflammatory bowel disease means reduced diversity of the microbiota, decrease of short-chain fatty acid producing bacteria. That is a major impact on the metabolism of the intestinal mucosa, increase of mucolytic bacteria. So you destroy the mucus layer and make thus for the epithelium more weak against other attacks, increase of sulfate-reducing bacteria, and obviously more pathogenic bacteria, decrease of energy source, alteration of regulatory T cells, mucus, as I said, enhancement of cell damage, and of course the permeability is a major factor. And you will get a shift. You don't need to follow that. The main thing here is that you have normally in the gut a balance between bacteria that are anti-inflammatory effective, and you have those that are pro-inflammatory effective. And in IBD cases, you mainly shift the balance here towards this Th17 regulated pro-inflammatory response with, again, the same major effects of epithelial damage, bacterial translocation, and then systemic inflammation that is a cascade that then maintains itself, basically. So this is not only IBS, IBD is also the very end of the spectrum when we talk about malignant disease. You see the same pattern again. So this is what I mean. We understand the pattern better, but the actual regulatory mechanisms behind it and what is inducing this, or is it just a consequence of presence of disease, is still something we need to elucidate. So the bacterium translocation, microbe molecule patterns are responsible mainly via toll-like receptors and not-like receptors to activate specific inflammatory response. There's a discussion also about local inflammation, local reactive oxidant species, and of course the whole metabolic effect that the microbiome has in that area, then finally leading to, that's the hypothesis at least, to a higher genotoxicity in the local area with higher mutation rates and making these areas then more prone for cancer development, also then leading to a higher oncogene expression, gene silencing, also what tumor suppressor genes respects. So one effect, I don't want to go too deep into that because that would fill another whole symposium, is then what's discussed is the impact of probiotica. So if you, with pro or prebiotica, if you can modify not only the mucus layer, but also the composition of the bacteria and restore a kind of healthy epithelial barrier, including not only the epithelium itself, but also the mucus distribution. So there's a lot of research going into that, what effects probiotics can have in these effects. So as a final chapter, before I want to conclude, just a few words also on microbiota and metabolic diseases. So we also know that with the mechanisms that I explained before, also modification of local energy sources. Let's talk about short-chain fatty acids, let's talk about bile acids, not the human natural ones, but the microbial generated bile acids. You get a different impact also on metabolic disorders. You have an influence on the body weight, so your metabolism is different, but also in obese people you have a different diet. So again, it's a bit of a shift going back and forth. You have an impact on insulin resistance and diabetes type 2 mainly, and on choline metabolism. So if you look at the different impacts, it's again lipopolysaccharides that cause inflammation, mainly toll-like receptor mediated and then NF-kappa B dependent. You have short-chain fatty acids that have a major impact on general metabolic effects, lipogenesis, glucogenesis, but also in muscle and insulin resistance. And bile acids, as I said, not only have all these factors also cause a shift in luminal pH, but also in certain, here TGF5 is a bile acid depending receptor that also mediates certain metabolic effects. And that not only happens in the liver, so dysbiosis in the gut has an influence on non-alcoholic fatty liver disease. There is a clear association, but again, we need to further understand these different pathways that are going here. Again, the bile acid receptor. Here again, we come with the lipopolysaccharides and the inflammation-related effects, and short-chain fatty acids that then indirectly feed back on the liver. But also, we don't need to go through all of that in detail. It is in all the different organs where these mechanisms through the mucus layer, through the epithelium, and the different inflammatory or metabolic responses have an influence on adipose tissue, on the liver, on muscle metabolism, even directly in the pancreas, and as mentioned before, the gut-brain axis also mediating satiety and other effects. So it's furthermore acknowledged that metabolic diseases and upfront type 2 diabetes or non-alcoholic fatty liver disease is more a triangle between the immune response of the host, metabolic effects that are modified by all of these factors, and the gut microbiota being one of the key players in this triangle. So let me conclude this brief outlook in an exciting field that's just rolling up in front of us. The upper GI microbiota are much more diverse than we had expected until, let's say, 20 years ago. The impact of PPI treatment, I have not touched on this, but also the balance of Helicobacter. What does Helicobacter eradication, what does proton pump inhibitor treatment on the gut microbiota? It needs also to be further elucidated. There are changes that we know, but are these relevant for our health? This is still under evaluation. There is gut dysbiosis involved in irritable bowel syndrome via the gut-brain axis. Gut microbiota are altered in IBD, but again, is that a consequence of IBD or is that mediating IBD? There is an impact of gut dysbiosis on colorectal cancer development. There's an impact on metabolic diseases, upfront NAFLD and type 2 diabetes. And what I had no chance to touch, but it's another amazing field. I think you give a talk later, Joses, on fecal transplantation, is how can we influence and what are our means to shift this balance back in a kind of healthy way. Is it prebiotics? Is it fecal transplantation? This is obviously a complete new topic. So thank you for your attention.
Thank you. Any questions? Rosas?
Yeah, thanks for a fantastic overview. I think we are currently a little bit overwhelmed by all microbiota data. It's basically deregulated in virtually all diseases. And researchers are a little bit stuck with where to go further. So what do you think? What's with your expectation? Where will the next breakthroughs come? What we need to do next? Because we see that in all diseases, diversity is basically reduced. So where we need to head further in microbiota research? What's your impression?
That's, I think, the most important question. I cut out this slide for time restrictions, was one of the openers. So if you look at the publications, this is just up to 2016 on the term microbiome in the title, and you see there was nothing happening till, let's say, 2010, and now it's like exponentially going up. It's exactly what you say. We have now an abundance of papers, but we need now to sit back and understand these papers. So this is similar to what happens in genome research with all the sequencing data. It's good to generate it, it's good to get a feeling for it, but at some point you need to sit back and say, okay, stop, what do I do with this? So I can't tell you where the next breakthrough is, but I think part of it is now thinking about rather interventional studies to see with, let's be probiotics, or you will later tell about fecal transplantation, what actually happens when we try to shift back. So one is, can we actually influence the gut microbiota willingly, or is it when I drink my Yakult, is it just gone in the evening again and my normal microbiota is restored? What are the effects? Can we modify it? And if we modify it, can we do that in a targeted way? I think this is something now to understand, and if we understand this, and if we understand how to modify, then we can draw mechanistic conclusions on this hen and egg problem, like is it influencing the disease, or is the disease influencing the microbiota? And I think this should be the next step, but I think there's still lots to be done.
Thank you. Any other questions? To continue the same, actually, there are some intentions to make some data pooling, to make some data lake, collect all the data from available data sources, put all of this together. Is this valid for microbiome research, by considering that different technologies are there, different pre-analytical factors? Do you see a perspective?
No, not at the moment, for exactly the reason you just mentioned. I was fascinated just sitting by, listening to a conversation of Christian Schulz with one of our colleagues from London, when they talked about different studies and the different techniques that can be used. You could just see by Christian Schulz data, even the material itself is relevant. So if you take a biopsy, if you take aspirates, the same for the colon. Mostly it's stool analysis, but maybe with the biopsy we get a completely different depth. And this is just the material. That's not even the assay. So what do we do? Do we do 16S sequencing, or do we do whole spread, whole genome sequencing of these areas? So with that, it's not possible, I think, to pool the data until you agree on some kind of key quality and SOP factors, how these studies should be generated, which would make pooling possible. Because that would be desirable, to get the bigger cohorts and actually see a whole picture. But at the moment, it's not possible.
Okay, thank you. Any other questions? If not, thanks, Jan. And now we are starting with our abstracts, and I'm welcoming Olga Siomina with a presentation on the association of pepsinogen levels and the HP status from a population-based cohort.
Dear colleagues, my name is Olga Siomina, and I'm very glad to be with you today. I'm glad to present the results of our research. Some of colleagues are partially acquainted with the results. The research is about association between pepsinogen level and H. pylori status, population-based study. And how does it work?
You need to use the
Which one? Oh, okay, thank you. So for introduction, I would like to say that gastric cancer, as you know, remains one of the deadliest diseases with poor prognosis, and now it takes the second leading place of cancer-related deaths worldwide, and remains the fourth most common cancer. And gastric mucous atrophy is the first specific recognizable step in precancer processes, and some serological tests can be used to predict the possibility of atrophic and pre-malignant changes of gastric mucosa, and also infection with H. pylori. It's associated with chronic atrophic gastritis, and these two factors are thought to be two major risk factors for gastric cancer. Aims of our study was to correlate the endoscopic and pathology findings in subjects with pepsinogen chest check, and to evaluate the relationship between pepsinogen test results and H. pylori status, as well as influence of eradication of PG level. Our study was a part of a great population-based study in Latvia in cardiology. There were 3,500 subjects from the register. Half of them were checked for pepsinogen test level and H. pylori serology, and then they were invited for the follow-up tests after 3 to 5 years, and 259 patients participated at follow-up, and they were included in our study. The age ratio was between 22 to 88 years old, and we divided patients according to the results of PG levels. There were 3 groups. First group were the patients with normal pepsinogen tests, with PG1 more than 17 and ratio more than 3. And another group were the patients with decreased pepsinogens, less than 17 PG1 and ratio less than 3. And the subgroup of them, this subgroup of these patients with decreased pepsinogens were the patients with strongly decreased pepsinogens, less than 13 nanograms per milliliter for PG1 and less than 2 the ratio. At follow-up, we took pepsinogens one more time to compare them, and histological tests were performed. And here are the results. Epidemiology, age and gender according to the PG test. You can see that mean age and median age increases from the group with normal pepsinogens. Mean age was 52 years old to 64 years old in group with strongly decreased pepsinogens. Also, here we can see that in group of females, the bigger part, or almost a half, 51%, was presented to group with normal pepsinogens. For males, we see that a bigger part, 57%, was in the group with moderately to strongly decreased pepsinogens. On this slide, I'd like to show you the distribution of precancerous lesions between PG test groups at follow-up. So the correlation of the results of pepsinogen test results and histological findings. In the group with normal pepsinogens, almost all the patients had normal or low-risk changes of gastric mucosa. Only 2% of them had dysplasias. In the group of moderately positive pepsinogens, we can see that only 76% of patients had normal mucosa, and already other parts, 1/3 of the patients had high-risk lesions, high-risk or premalignant lesions, Olga-3 for, Olgin-3 for, corpus atrophy or dysplasia or even cancers. And the third group was strongly positive pepsinogens, and here you can see the decrease of the amount of normal mucosa. Here the third part of the patients had premalignant changes. Also the pepsinogen, not the pepsinogen but H. pylori was checked, and we checked the amounts of H. pylori positive patients and different groups of pepsinogen results. And also here you can see the increase of proportion of H. pylori positive patients from the group with normal pepsinogens to group with decreased pepsinogens. Here I would like to show you the status of PG test and H. pylori at the follow-up. You can see that we also divided patients according to the H. pylori status in 3 groups. There was a group of patients with negative H. pylori. Second group was patients with positive H. pylori without reported eradication therapy. And the third group was patients with positive H. pylori without, with eradication therapy, so the patient who underwent eradication during this follow-up period. First group, here we see the patients without H. pylori, so H. pylori negative patients, and a bigger part of them, so 55%, had normal mucosa and normal pepsinogen test levels. Second group, it's H. pylori positive and patients with reported eradication. Almost 70% had normal pepsinogen test levels. And here we can see group with positive bacteria and without eradication. 60% of them had decrease of pepsinogens. And here I'd like to show you that we checked also the dynamics of PG ratio changes between baseline and follow-up according to H. pylori status. And here I would like to show that in the group with negative bacteria and of course negative eradication history, ratio didn't change. No significant changes were found. In the group with positive bacteria and negative irradiation, so irradiation wasn't performed, we see the significant decrease of PG ratio. And opposite situation was found in the group with positive bacteria and positive eradication history. We saw the significant progress, so increase of PG ratio. 2 cases of gastric cancer were found during our study, and both cases of cancer were in the group with decreased pepsinogens, in the group with positive H. pylori infection and without eradication. Other characteristic in both cases were quite the same. Age group was more than 70 years. One case was female and one case was male. To conclude, I'd like to say that all high-risk gastric precancerous lesions at follow-up were observed in patients with decreased pepsinogen test at baseline. Sensitivity is quite good, but specificity of test is not enough, of course. And another one conclusion that PG test, especially in combination with H. pylori positivity, could predict premalignant changes of gastric mucosa, and this test could be used to predict malignant changes without deeper investigations. Thank you for your attention.
Thank you. And actually, we are always debating because usually it is the opposite, but of course it is depending on how you are calculating the sensitivity and specificity.
Yeah.
Because usually we are considering that sensitivity is insufficient, but the specificity is good for pepsinogens. You are the opposite. But maybe you can come back to these cancer cases and we can discuss maybe more of those, although these are only 2, but nevertheless these are important. So how decreased pepsinogens they have had?
One case was found in the group with moderately decreased pepsinogens. Yeah, so the PG1 was 6 and 64, and ratio was 2. And another case was in strongly decreased pepsinogen group.
We can just debate whether 2 cases out of 250, that is lot or it is not.
For
pre-selection.
For this group, I think 2 cases are enough. But also I'd like to invite you to the second part of gastroenterological session today. My colleague Elizaveta will discuss more deeply about cases of gastric cancers.
Olga, very nice presentation.
Thank you.
Charming. The issue for me is how did you define your population? Because it looks like a selected cohort.
So it was a part of previous research in cardiology. So it was 3,500 patients from register, random patients. Yeah, and they were invited for our research. So we sent letters, and who came? they came. Maybe it's a preselection.
Because the data, Marcis, they are very different from what I learned yesterday. You have about 20% in females, 19 in men more, percent of severe reduction of pepsinogen, which, as I understand, in the blister you have about 7% of abnormal pepsinogen. And the second thing what I really would like to understand, and I would be very offensive towards pathology, I don't think that you have 60% severely decreased pepsinogen in normal mucosa. So, since you said it's an endoscopy histology based, see 61%.
Yeah.
Based on Olga and Olga, right? It's in all of them it was performed.
Yeah.
The same, this is, I mean, you know, biopsies are taken from foci, and pepsinogen is very stable, no? As a proenzyme. And why should it be so frequently abnormally low in 61% of it? This is to me a figure I cannot understand. So I think either the pathology is a problem or the endoscopy did not select the right foci. So without using maybe a high definition endoscopy, this will be difficult as a next step.
I can maybe add a bit to this, to the methodology. All of those that were invited had initial measurement of pepsinogen that was decreased. But the question is what cutoff value you are using for us. And it was quite wide. So meaning that the initial selection was quite extended to what we really consider should be the actual. That's the reason why also the majority, the big proportion of the patients did have normal pepsinogens, but you are absolutely right. With the decreased pepsinogens, that is an issue. What is the reason there of having decreased pepsinogens?
But your factor is another important one. You said it depends, maybe you can comment on the cutoff. How did you establish the cutoff?
Of
Because
pepsinogens?
you changed it, yeah. What was your receiver operating curve in this respect?
You mean this pepsinogen cutoff,
no,
or?
Because as we know, the producers give you a cutoff, then the population of Latvia has a cutoff, and the population of Italy or Germany. We have different cutoffs.
Yeah,
so how did you get to this cutoff?
We use previous researches, and we try to compare our results with previous researches, and we found that usually use this cutoff is 70 and 3, and also we decided to check this lower
but because
cutoffs.
if you lower the cutoff here, maybe you have only 20 or 30%.
Maybe, yes.
So this is
problems with methodology,
okay.
yes. Thank you.
Nice.
Thank you.
Okay, so now we are, please take the seats, we will have the seats here in the room, and now we are moving to two very interesting presentations on the data that have been obtained from a sample from the G-STAR study, pilot sample in Kazakhstan. So in the middle we're going to present data on the prevalence of Helicobacter in Kazakhstan based on this.
Un kur ir gaismiņa? Un gaismiņa te ir?
Zrīt šitā augšā. Tur uz ekrāna.
Good morning, dear colleagues, students, professors. My name is Linda Mežmele, and I'm a fifth year of medical student of University of Latvia. And today I would like to present our part of G-STAR regional pilot study, prevalence of Helicobacter pylori infection in Kazakhstan. And before I start about our results, I would like to mention some information that Helicobacter pylori is a worldwide infection, and in South and East Europe, South America, and in Asia, the prevalence of Helicobacter pylori is often higher than 15%. And Helicobacter pylori infection is an important etiological factor of the occurrence of non-cardiac gastric adenocarcinoma. And in November 2016, 3 requirement sites for the G-STAR regional pilots were opened in 2 centers of Almaty and in 1 center in Semey. And training of the local staff was conducted by specialists from University of Latvia during the 2-week stay in Kazakhstan. And the aim of the study was to evaluate the prevalence of Helicobacter pylori positivity and the affecting factors in general population sample from Semey and Almaty cities in Kazakhstan. And respondents who included in our study was from 40 to 64 years old healthy individuals, and none of respondents included in the study had received Helicobacter therapy, eradication therapy before. And data were collected using standardized questionnaires, blood samples were obtained and stored frozen until analyzed. And the antibodies to Helicobacter pylori were analyzed in plasma by latex agglutination method, and the cutoff of Helicobacter pylori positivity was over 24 units per milliliter. And statistical analysis was performed using Microsoft Excel and using percent chi-square test. And the level of statistical significance was set off p over 0.05. If we speak about description of the study population, that out of 177 screened participants, 177 individuals were included from 3 centers. But I need to mention that one of respondents didn't give his blood samples for our studies. And from Semey were 127 respondents. From Almaty was 8 respondents, and from Almaty Diagnostic Center were 32 respondents. And here you can see distribution of respondents by gender according to Helicobacter pylori positivity. And you can see that from all respondents, 62.7% were positive Helicobacter. And from all these positive results, were 66.3% were males and 57.4% were females. And after statistical analysis, there was no correlation identified between Helicobacter pylori positivity and gender. And the study included different participants with different nationalities, and Kazakh's population were 67.7%, Russian were 27.5%, and other ethnic groups were 4.8%. And here you can see that from Kazakh's population, 67.1% were Helicobacter seropositive. From Russian population were 50% positive results. And from other ethnic groups were 87.5%. And the prevalence of Helicobacter pylori positivity was higher in the Kazakh population than in the Russian population. And as I mentioned, that age of respondents were from 40 to 64, and median age was 51, and all individuals were distributed in 5 age groups under less than 45, 46 to 50, 51 to 55, 56 to 60, and over 60. And here you can see that in all age groups were more than 50% Helicobacter pylori positive results. And the highest prevalence was in the second group and in the first group. But after statistical analysis, no correlation was identified between increasing age and Helicobacter pylori positivity. And our conclusions are that in Kazakhstan, high prevalence of Helicobacter pylori was revealed in a general population sample from Kazakhstan. In Kazakhstan population, age and gender did not have an effect on the prevalence of Helicobacter pylori infection, and the Kazakhs were more likely to get Helicobacter pylori than Russians. And thank you for your attention.
So, any questions, comments?
Comment. Thank you. Very nice. It's interesting, and it's really different from the general. So we learn from this population. In the western part, you have always an increase with older age.
Mm-hmm.
Right?
Yes.
Because of the cohort phenomenon. Here it seems
Lower, yes.
the other way around.
Yeah.
Could you have other factors that would explain how is their lifestyle? Is it not also adapted now to Western lifestyle? Is there still refrigerators missing? Is there still a different tradition in food, in how they eat together?
Yes, probably in Kazakhstan they have like different kind of eating habits, and one of the factor which I read in literature is that Kazakhs have like very large families, and probably this Helicobacter infection prevailed in Kazakhstan population because they, for example, use the same dishes in like big families, and that's why it's one of the factors.
That's very interesting, because if they maintain this type of sharing the meals, even in the population of the 5 and 10-year-old, we expect to have the same.
Yeah.
Prevalence. It would be interesting to see, maybe even with a stool antigen test for a population to see, because this is, very special. Maybe, it's very interesting. The other explanation why it's going down, what could be an explanation? That the older people have less because they ate in the same way.
Maybe that's why you can see that there is only 20 respondents in largest age group, and maybe if we will have, like, for example, a large population from other age group, probably results will be like different, because there is not very a lot of
it's not big enough, size. That's a good explanation. The other explanation, if you know from general course in the Western populations, it's once you get above 75, 80,
yes,
then you drop, because there is a higher prevalence of atrophic gastritis, and then Helicobacter disappears, even serologically after. So you have an increase up to 75, and then you have a decrease.
Yes.
Although the people have been infected, but the stomach is no longer harbored. That's the other explanation. But I think the size is also good. Yeah, nice.
Thank you. And we are continuing then with we are continuing with the next presentation on a similar topic, in a similar population by Anna Krieger, who is going to speak on pepsinogen levels.
So good morning, dear audience. My name is Anna Krigera, and I'm also a fifth-year medical student at University of Latvia. And today I would like to carry on discussing this topic, the G-STAR regional study in Kazakhstan. But my presentation will focus on the prevalence of decreased pepsinogens in Kazakhstan. So serum pepsinogen 1 and the ratio between pepsinogen 1 to 2 are related to the histological and functional status of the gastric mucosa. And low serum pepsinogen 1 and the ratio values are the biomarkers for atrophic gastritis. And it is known that atrophic gastritis is a precancerous lesion of gastric cancer. So the aim of this part of the study was to evaluate the prevalence of decreased plasma pepsinogen levels in a general population sample from 2 cities in Kazakhstan. And to correlate these decreased pepsinogens to Helicobacter pylori serology. So in order to do this, blood samples were obtained and stored frozen until they were analyzed. And pepsinogen 1 and 2 levels and antibodies to Helicobacter pylori were analyzed in plasma by latex agglutination method. And now the cutoff values for these factors. So for decreased pepsinogens, the value was set at the pepsinogen 1 to 2 ratio being less than or equal to 3, and pepsinogen 1 being less than or equal to 70 nanograms per milliliter. But for severely decreased pepsinogens, the value was set for the ratio for less than or equal to 2, and for pepsinogen 1 for less than or equal to 30 nanograms per milliliter. But the cutoff value for Helicobacter pylori positivity was more than 24 units per milliliter. And so the description of the study participants. So together 167 individuals were included in this study. And the age of the study participants was from 40 to 64 years. The median age was 51. And all of the respondents were distributed into 5 age groups. And if we look at the distribution of these participants by gender, we can see that 59.3% were male participants and 40.7% were female participants. And as my colleague already mentioned, the distribution of the study population by their ethnicity was 68% were Kazakh ethnicity, 27% were Russian, and 4.8% were other ethnicities. And now I would like to move on to the main results of this part of the study. So in this graph here, you can see the distribution of pepsinogen plasma values in all of the age groups. You can also see that the majority of participants in all of the age groups had normal plasma pepsinogen values. However, altered plasma pepsinogen values were also detected in all of the age groups. If you look at the age group here, 51 to 55 years, you can see that the proportion of both severely decreased pepsinogen values and decreased pepsinogen values was the biggest among all of the age groups. You can also see that this proportion gradually increases with increasing age until it reaches the age group 51 to 55, and then it slowly stays the same in the same proportion, but it slowly decreases. And after doing statistical analysis, there was a correlation identified between the increasing age and both decreased and severely decreased pepsinogen levels. And this graph shows us the association of pepsinogen levels and gender. And you can see that there isn't a significant gender difference in the decreased plasma pepsinogen values. And also, the statistical analysis didn't show a correlation between gender and these decreased pepsinogen levels. And here you can see that 16.3% of all of the respondents had decreased plasma pepsinogen values, And 9% of all of the respondents had severely decreased plasma pepsinogen values. And from those respondents who had decreased plasma pepsinogen values, 70.4% were Helicobacter pylori positive. And from those respondents with severely decreased plasma pepsinogen values, 33.3% were Helicobacter pylori positive. But the statistical analysis didn't show a correlation between Helicobacter pylori positivity and decreased pepsinogen values, but there was a correlation with these participants having severely decreased pepsinogen levels. And some conclusions I would like to mention are that decreased pepsinogen levels were more likely in subjects with higher age, and that the severely decreased pepsinogen levels were associated with Helicobacter pylori positivity, and the gender was not related to decreased pepsinogen levels. Thank you for your attention.
Thank you. And yeah, do you think that percentage is acceptable of decreased pepsinogens? Could we accept higher or lower in this case?
Here you can see the absolute numbers in this graph here. That's why they are like this. But after doing the statistical analysis, we could see that there was a correlation between these severely decreased pepsinogen levels and Helicobacter pylori positivity, whereas here there are absolute numbers and it doesn't always show in the same direction.
Thank you. Other comments, questions? Yes, please.
How do you explain the fact that when this correlation that you obtained, that in case of severely reduced pepsinogen level, it doesn't really work with the indications that it is highly positive? I mean, the severely decreased and decreased, the results are opposite. How do you explain this correlation?
I'm sorry, I didn't actually get the question, didn't hear it.
This is the slide that you showed.
Yes.
How would you explain that the fact that severely decreased pepsinogen level correlates with 30% of Helicobacter pylori positive? And is it right? Is it, I'm not looking at severely, no, sorry. Severely is the purple part, right?
No, the purple part is the part of the participants that had positive Helicobacter pylori serology.
No, I'm looking at the big part.
You mean this?
Okay, well, we can discuss it later. I can't see that part very well, so probably I'm just missing it. It's all right.
Okay, you can come to me after and I can maybe, okay. Thank you.
Yeah, anyhow, it's interesting, no? We think along this, that you have the low proportion of Helicobacter positive, it's quite logical, in the group with very low pepsinogen or severe. And you have still a high number of infected. So it would be interesting now to see the endoscopic histological criteria. You have them already?
That's the next part that's happening. We will match these results to biopsy results and see what's actually in the gastric mucosa.
They have all been endoscoped, I suppose.
Yes.
Right?
Yeah.
Okay. No other questions? Then thank you.
Thank you.
Actually, this will be the next part of the work, but not the next presentation, because the pathologists are not here and maybe the data are not yet analyzed. But we are proceeding to another presentation now, and we are switching the topic. The topic will be the evaluation of azacitidine therapy with patients diagnosed with inflammatory bowel disease. And the presenter will be Polina
Sorry. Okay. Okay, thank you.
So, dear professors, dear audience, I'm appreciated to be here today and to present you our study. It will not be about Helicobacter pylori or microbiota, it will be another theme. Yes, so I would like to start with such interesting theme like therapeutic drug monitoring. So as we know, it's the guideline for future medical treatment as it considers the individual variability of pharmacokinetics and thus enables personalized pharmacotherapy. And as we know, inflammatory bowel diseases are widely treated with thiopurines, and individual thiopurine metabolism actually will affect the results for IBD patients, as such adverse effects like myelosuppression can lead to very life-threatening complications. And American Gastroenterology Association Institute guidelines suggest thiopurine monitoring with an enzyme called TPMT, either phenotype or genotype. I will tell about it later. So what we are using mostly in Latvia is azathioprine drug for treatment IBD patients, and in some cases also mercaptopurine. A little bit about metabolism of thiopurines, so you can understand about TPMT enzyme. It is actually used in metabolism of thiopurines in 80% of cases. Another one is also HPRT enzyme, but it is not so involved in metabolism. About adverse drug reactions, there are many. On the 39%, it is abdominal liver function disorders, and also allergies, bone marrow toxicity, pancreatitis, and malignancies. We can divide actually adverse drug reactions into two, like early and late. And the difference between them is that the late adverse drug reactions are associated with lymphomas. And about TPMT gene, what I would like to say that in most common it is LLTPMT1 that is present, but if there are any different localizations of nucleotides, then we have decreased enzyme activity. So here, for example, if we have TPMT wild type, like normal activity will be, but if we have some heterozygote or homozygotes for TPMT gene, then it will decrease TPMT activity level. It is interesting that in different population it is different. Frequencies. In Latvia it is not have done before. It is just next step of our work. And what we see also the correlation between TPMT and genotype and phenotype, that if it is normal genotype, then we see very good activity of enzyme. But if it is heterozygote or homozygote, then it is decreased. So about phenotype, as I mentioned, it is a really different adverse effects can be lead to the patient, but still very interesting that very high TPMT can show us that there will be no therapeutic response on the therapy. So here are some advantages and disadvantages of phenotype test. We can see that this hyperactive metabolizer is very important. Disadvantages is that phenotype can be inhibited with different medications, but for genotype it is an advantage that DNA is more stable and it is not sensitive for transport, not so sensitive for transport conditions. But still, the normal genotype does not exclude possible adverse effects. There are different algorithms how to monitor type purines. But what was the aim of our study is this TPMT enzyme expression. We first start still with the phenotype because the genotype in our study will be the next step. So what we have done, we have selected 20 patients with IBD from age 22 to 79. All patients were in Paul Stradiņš Clinical University Hospital in last year, and all patients had exacerbation of IBD. So we have performed this test, we're first in Latvia who performed this test of ELISA method. And what are our results? That ulcerative colitis patients were 70%, Crohn's disease patients were 30%, and that patient who were not used before azathioprine was 75%. At this moment, patients were using azathioprine, it's 10%, and 15% who had used it before and stopped due to different adverse effects. So also, of course, patients, our patients had basic treatment for IBD. It is peroral 5-aminosalicylate therapy and also local therapy and combinations of it. And what we see from results of our test that we performed in the University of Latvia, it is so that 3 patients has decreased TPMT expression and 2 of them has extremely decreased. So what does it mean? That this patient has not are not allowed to start azathioprine therapy, and this is good that all these patients, these 3 patients, did not use at this moment azathioprine, so we can predict that azathioprine will not work for them, or will or they will have some adverse effects. So that's why we have to go to step-up therapy. We have to think others about others medications. So this was the results of our study. It's confirmed that it is quite important. In such pilot study, only 20 patients involved. 3 patients were found with decreased TPMT enzyme. And next, our step that we are going to see genetics. So this is what I would like to talk about today, that it is very important to personalize therapeutic drug monitoring because then our main idea that we want to achieve histological healing for IBD patients. But still there are no strategies all over the world how it's to do better, and it's needed further studies. Thank you for your attention.
Thank you indeed for the report. Any questions, comments? May I ask
you, because this issue of TPMT measurement has been around for already quite a few years, and this has been debated quite a lot. What are your recommendations? Just to start investigating the background before giving any as type 1 to any patients or not, or still to limit the monitoring to the cases having any problems?
Thank you for your question. Yes, what we think and what we have already started in our hospital, it is that for all patients who we need that we would like to start azathioprine, we perform phenotype tests. Yeah, not genotype, but phenotype, and we are doing it. It's more than 20 patients who are already performed for this test. And the results shows that yes, there are some intermediate levels of TPMT, but are also very decreased. And then, of course, we choose next step therapy, for example, biological therapy for these patients. And actually, what I want to say that this is very important to very young patients who are like children, and for elderly patients, because thiopurines have a most severe risk for elderly patients. Yeah, so we have always, of course, this is also the question who will pay for these tests, because these tests are not so cheap. But I hope that our government in future also will do some changes so they can help patients to predict if they are, can have this medication or not.
Thank you. So the testing is available and you are doing this on
Yes.
Yes. Okay, thank you. Great. Thanks. If no other questions. Now it's my great pleasure to invite our guests from Lithuania, and the topic will be the first experience of FMT for C. diff infection, and we are really looking forward to hear what Dr. Linda Vasurbo will say about this.
Thank you for your introduction. Good afternoon, dear audience, dear professor. Today I would like to present our data from Lithuania about fecal microbiota transplantation for recurrent Clostridium difficile infection. And first of all, I would like to define the recurrent Clostridium difficile infection. What it is. It can be defined like Clostridium difficile infection, which recurs within 8 weeks after the onset of a previous episode with repeated symptom of CD infection symptoms from previous episode after effective initial treatment. And as you can see in this slide, the first recurrence can occur about 1/3 of all patients after the initial episode of CDE. And as you can see, the second and more recurrences can be observed in more than the half of those patients. Why it is important? Because the recurrent CDI is associated with significantly increased mortality within 6 months. And it is important to know the prognostic factor for the recurrence of Clostridium difficile infection. And according to the European Society of Clinical Microbiology and Infection Disease, you can see that it is age, more than 65 years, yes. Continued use of antibiotics, it's very important in daily practice. Comorbidity, also very common in our daily practice. And a history of previous CDI, and of course, initial disease severity. And if we talk why we must choose the fecal microbiota transplantation but not the standard antibiotics regimen for recurrency Clostridium difficile infection. Firstly, it is important because, as you can see from these two randomized controlled trials, which compare different fecal microbiota transplantation methods first one by via nasogastric tube and the second via colonoscopy. These two methods are statistically more effective than the standard regimen of vancomycin, as you can see. And the second reason why we must choose the fecal microbiota transplantation is because it is more cost effective if you compare it with vancomycin. And in the second part, I would like to present our data. Our purpose of this study was to evaluate our fecal microbiota transplantation effectiveness for recurrent Clostridium difficile infection therapy in our hospital. Also, we evaluate the trends of CDI infection in our hospital. And as you can see, our history of fecal microbiota transplantation began in 2015. And we analyzed all these clinical data of patients who were treated in this period in our hospital for recurrent Clostridium difficile infection. And as you can see, in our country, in our hospital, we have increased incidence of Clostridium difficile infection, enterocolitis. And the most reasonable explanation for this is because in our hospital we use more wide spectrum antibiotics. So it is the main table of our study. As you can see, 26 patients have fecal microbiome transplantation via the nasoenteral tube and 2 via an enema. And if you talk about first group, you can see that the primary cure rate is about 76.9%, and you can see that 6 patients have the second fecal microbiota transplantation. Why? These patients, most of these patients, 5 out of 6 patients, were on immunosuppressive therapy at first initial fecal microbiota transplantation, and only one out of 22 patients was without immunosuppression. And in this slide you can see our magic capsule. At the moment we have 4 patients who get the microbiota transplantation by the oral capsule. And as you can see, 75% have success after the initial transplantation, and only 1 patient need secondary fecal microbiota transplantation, and we have done it through the nasoenteral tube. So in the conclusion, I can say that in our country and hospital we have increased incidence of this infection. Fecal microbiota transplantation is effective therapy for recurrent Clostridium difficile infection, and the effectiveness of fecal microbiota transplantation can be associated with immunosuppression. Thank you for your attention.
Thank you indeed, and congratulations with really the first patients and first results. And although it sounds like an anecdote to some of the experts a few years ago, but now it is really everyday clinic. I have a bit missed these capsules were your own produced, or these were of the commercially available?
Oh, not commercially available at the moment.
You are producing them?
Yes, we are trying to do the...
doing all the testing and all of this stuff before the fecal material is being used? What about the donors?
We find some medical student who want to help the patient being the donor. We are, of course, testing them from the hepatitis C, hepatitis B, anti-HIV, and other infection. And we have several donors
Several.
Yes, 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 yes.
How many of the donors? You don't have too many patients. Usually one.
So, but we try to change
evaluated.
them. To try to change the donor. So.
Okay, very interesting. Other questions?
About the incidence, maybe is that due to greater awareness of the disease? With what we look, we just had more tests done, so we see incidence increasing over the last 3 years. Looks like it's just more talking about it and more diagnostic interest in the disease.
So in our hospital experience, maybe the can explain only with the wide spectrum antibiotics, because it is a university hospital and it is not necessary to additional information about this infection. So maybe in other district hospital it can be due to the higher incidence rate because there are more knowledge of this infection. But in our hospital is due to the wide spectrum antibiotics usage.
Yeah.
I'm always fascinated by this topic. Is there any data what happens when you feed these to healthy people? Is there any effect, like if you take these capsules, which you might have in you, is there any effect when someone without disease takes these capsules?
Are you getting ill?
I don't know. Is there data? You give it
Joseph wants to comment.
I'm talking about like with any medication, your first line studies that you give it to.
If you have a patient with infection but without antibiotics, and first of all,
well, if you give it to a healthy person like one of us, if we would take these capsules, would we have any effect? Is there any data that says like I feel better or I lose weight or?
Probably ethics were not allowed.
I don't.
Phase 1 studies.
I don't know that study who are trying to.
Give a short comment on that. No, there is no such study, and the problem is that with fecal microbiome transplantation, they're becoming very strict and regulating. In USA, it's now on the level of any other drugs. You have to get drug administration permission for any kind of study. But it would be interesting to see from the academic point of view. I think eventually some data will be available. And to comment on the prevalence of Clostridium in our university hospital is when I was still a student, we almost had no infections of C. This is something we read in books and only happened in Western countries. But due to better availability of wide spectrum antibiotics last year, I think this is the trend that we are becoming more westernized in general. So we have more of this infection everywhere. And it's not in our hospital, it's everywhere. So I don't know what's the experience.
Did you type them? Maybe you have this new serotype or
no, we don't serotype.
Ribotype, sorry.
Yeah, we don't do the different subtypes. We don't do this. But,
the ribotyping.
So that there are more aggressive ones.
Yeah.
I agree.
We
haven't looked at this.
Maybe you would like to comment on this need for Latvia, you are really the expert in this field. Not in FFP.
No, I think that we have patients nearly all responding on vancomycin, oral vancomycin. I've never seen the non-responders so far, so I think it's due to ribotype. So it's 0120, which is now in most of the European countries we don't see the ribotype, so it would be interesting to do the ribotyping study in the hospital, and maybe that could be another explanation. Because ceftriaxone has been used widely for the last 10 years, so it's not new, the wide spectrum antibiotics. I can't believe that you have been starting using more antibiotics over the last year or two. But anyway, so.
Thank you.
Actually, that might be a good possibility for a collaborative study. Okay, thank you. And now we have another interesting topic on the correlation of fecal microbiota with liver steatosis risk factors in patients with non-insulin dependent diabetes mellitus. And Simonur Bondovo is sorry for pronouncing
Doctor. Okay. So, dear colleagues, dear audience, my name is Semanur Gündoktu, and I'm a sixth-year medical student at the LU. And today I would like to talk about correlation of fecal microbiota with liver steatosis risk factors in patients with non-insulin-dependent diabetes mellitus. So first of all, about the background, non-alcoholic fatty liver disease is nowadays affecting up to 15 to 30% of our population, especially in the Western countries. And its prevalence is rising up to 75 to 90% in type 2 diabetes patients. So non-alcoholic fatty liver disease may progress to a NASH, then with further development into liver fibrosis and cirrhosis, and finally hepatocellular carcinoma. So the risk factors for the development and progression are central obesity, low HDL, high triglycerides, hypertension, type 2 diabetes mellitus, and high alert levels. So it has been also postulated that dysbiosis causes a systemic translocation of the bacteria and thus contributing to the hepatic inflammation. So our aim was to analyze an association between those the fecal microbiota at the level of phylum and genus with serum alert levels, triglycerides, BMI, and waist circumference. So we collected data retrospectively from newly diagnosed type 2 diabetes patients, which were included in the Optimed study from June 2015 until May 2016. And the exclusion criteria were the use of any drugs such as antibiotics, antidiabetics, corticosteroids, or corticosteroids in the past 2 months, some allergies to the prescribed antidiabetic treatment, chronic diseases, alcoholism, and diarrhea during the previous weeks. And anthropometric measures, blood samples and fecal samples were analyzed. And for the fecal samples, 16S RNA gene analysis was performed in order to detect the phyla and genera of the bacteria. So we received anonymous data of 18 patients from the Latvian Biomedical Research and Study Center. And due to the lack of microbiome data of 7 patients, they had to be excluded, unfortunately. And so we had our cutoff value was for alert was 29 for males and 22 for females. The statistical analysis was performed with SPSS 25, and in the end we had a total of 11 patients between 49 and 79 years, and the median age was 68. So the females were represented 45.5% in our studies and males 54.5%. So 7 of our patients had an increased alert, and the alert-based groups were formed to be as homogeneous as possible. However, our increased alert group included slightly more women, and the BMI was slightly higher in the alert group. But we didn't find any significant differences in those both groups, in the increased alert and normal alert, as well as we didn't find any differences at the fecal microbiome composition in both groups. But I'm not going to show any table for that because it's really huge. But just to show it a little bit, you can see that at the level of the phyla, the microbiomes were equally in both groups, in the normal alert group and elevated alert group. This is just some examples, and also for the genera you can see here, they were equally. So talking about the diversity, we found out that at the level of the phyla, the Shannon diversity index related negatively with the triglycerides, and at the general level it correlated negatively with the BMI. So it means that patients who had a higher BMI and higher triglycerides level had a reduced diversity. So at the level of the phyla, we found significant correlation of bacteroidosis with the firmicutes. It was a negative correlation, as you can see here, and also with the triglycerides. So they are considered kind of as the good bacteria, because patients who had a higher level of those bacteria showed a lower triglycerides level and waist circumference. So the opposite phenomenon we could observe with firmicutes, which had a positive correlation to the waist circumference. and triglycerides. At the level of the genera, we found out that the triglycerides had a negative correlation to ruminicoxal UCG 002, subdolicranulum, and a negative correlation to the BMI was found with ruminicoxal UCG 004, Butyric and Holdemania, and a positive correlation with flavinofractum. Other correlation which we found out that was that a negative correlation to waist circumference with Holdemania, Bacteroidetes Pavibacter ruminococcus 2, and a positive one to Lactobacillus. So for the alert, we found out that a negative correlation with Blautzia or Bacterium hali group, and a positive correlation to the Rumbutzia. So about the conclusion, we can say actually that we didn't find any significant differences in fecal microbiota in the patients who had an increased alert compared to the ones who had a normal alert levels. But this could just be simply explained by our very small sample size. And the bacterial diversity was reduced in the patients with higher BMI and higher triglycerides level. As I just showed now, we found several correlations at the level of genera and phyla. And for the future, we can say, and well, actually we must say that we need bigger studies in which the microbiome maybe is manipulated and successive changes of the steatosis are examined. Maybe targeted microbiotic therapy could be a new option for those patients. So thank you for your attention.
These are great data, and indeed what we do have, we have growing evidence that steatosis is linked to microbiome, and this is great that we are doing this right now here. So any questions, comments? Yours, please.
One question from multiple studies which have been done performed on steatohepatitis. One of the bacteria which has been identified is Akkermansia. Did you see this bacteria?
Which one?
Akkermansia.
No, I have just written down the ones I found, but I haven't read this study.
I already know that we started the second phase clinical trials with giving this bacteria to patients with liver steatosis, and we see some nice results in the liver enzyme down regulation afterwards. So I was just wondering if you had this signal of the bacteria.
No, this one I haven't read, but I have read several other ones. Maybe I can, you can show me the study and just for the information. Thank you.
Yeah, please.
Just a comment also following on the last talk. If you talk now about modification of the microbiota with achieving improvement of steatosis or something, maybe you two should work together and you should do the fecal transplantation in these patients and have a look what that out.
Yeah.
Might be interesting. Maybe it's a step forward from here.
Yeah. Thank you.
I think some of these studies are really being done, and once more, it's not yet approved indications so far, but definitely on the study background, that would be really very, very exciting to look at this. Any other issues? Any other comments? If not, thanks. Other comments? If no other comments, I would just like to say some concluding words. We are really happy that we have quite full room. Maybe it's good that we haven't had much bigger room, but we have enough seats and we had really enough interest in this. And I'm really happy that people from neighboring universities and hospitals are coming already, not the first year, but I hope that this is going to be continued also in the future. And what I have recognized that there are also some people without the presentations, so there are possibilities at least to consider for the next year to have also presentations to others. And definitely very grateful that also Uga Dontis, who is really the great antimicrobial expert in Latvia, is present and is commenting on this. So thanks everybody. And we are a bit ahead of the time, but that was expected because we didn't have too many presentations. So now it is break and just follow the program.
It's